All right. Yeah, this is going to be a little more straightforward, I think. So this is a 21-year-old male who was in a motorcycle accident, brought into our county hospital. Uku, what do you want to get? What do you want to do on this guy?
Get him back.
Your definition of straightforward is a little different than mine in this context. I guess different background of the training. I want to see a close reduction views because, again, it's not going to change the surgical versus non-surgical. It's going to be surgical regardless, in my opinion, short of any other major issues. Because I sometimes surprised after close reduction, things looks significantly better, that I can fix it easily. If it looks that bad after a close reduction, I'm going to have the long plate. I'm blanking now, so the
bridge plate?
Bridging the rest plate available for sure before I start the case. I don't want to call it 2 hours after I started the case.
I want to call it in afterwards. Yeah. So I think the next slide.
Sorry, can I go? So I find injury films really, really, really helpful because once you splint them, you just can't see it that well, right? But then first thing that kind of jumps out to me is I look at the ulnar side as the DREJ, is maybe there's a TFCC tear because the wrist is so displaced radially. Even though sometimes you'll see like a styloid piece that goes with the wrist and you know it's torn. But then just the amount of displacement makes me wonder that there's going to be a TFCC repair. So TFCC tear that I might have to fix, right? And it does make it, if you work in a surgery center, you have to think about booking and your case length. And so I would probably add that to my consent as well. The x-ray, there's a radiostyloid fracture. It's split in half, like the ulnar, the lunate facet is split in half on the lateral view. This injuries, even though they look pretty bad, they break in this like predictable pattern. It's like a styloid dorsal wall. The lunate facet breaks in two pieces, the palmar and dorsal piece, and there's a lot of times a central piece that also breaks off. So I think, that for me would be, let's start with the information I would get from this.
Yeah. Tony, or sorry, Scott, we actually are doing something hand. Anything to add?
Well, further imaging, I don't know. I was going to ask the group, I don't do a lot of distal radius, but CT scan, would you consider getting a CT scan? Yeah.
Yeah. So I think the next one is the reduction film. Oh, sorry, CT scan. Reduction and then CT scan. Sorry. So we got a CT scan. And just like Nico said, I think I picked this case because it's really kind of everything that you want to learn about doing distal radius fractures. You see what he's talking about. If you look at the lateral scan, you see there's a piece, the lunate facet has been split dorsally and volarly. But if you look at the other kind of the coronal scans, you see that there's this shear through the radiostyloid fracture. And for me, that sets off alarm bells, or that lets me know that I'm going to have to do a different type of fixation when I see this type of styloid fracture. So the interesting thing to note on this patient, even though his, this lunate facet piece is flipped out and basically pressing on his median nerve, he has no median nerve symptoms on his exam. I examined this patient before I saw him. He wasn't even numb in the distribution before we did the surgery. So, Tony, what do you think we have to do for this gentleman? Or what do you think? What do you need to do, or how would you approach fixing this fracture?
Yeah, so it's not your run-of-the-mill, like 70-year-old woman who fell down, right? This is high-energy trauma, and you can see that in the amount of comminution. It's also short segment too, so your traditional volar plates probably you're not going to work, both because you have that dorsal ulnar shear pattern, which you can see in the carpus already, and wants to dislocate backwards. But you also have this volar piece that's also going to be important to keep it from volarly subluxing. So you're kind of hosed both ways, and I think you have to address that, and you also have the radial styloid piece. So traditional volar plating is not going to work for this. I think you need to consider other options, whether it's just spanning this, or if you have the instruments and the capabilities to do something more fragment specific.
Yeah, and I think it's a really good point, in that the main problem with this fracture is that the carpus is unstable, so the carpus wants to slide off. It wants to go back to where we started before, which is to go back dorsally like this. The fracture wants to go back to where it started. So just a quick show, like who, if anybody saw this, who would bridge this fracture? Like who would use a bridge plate on this? Anybody? Does anybody routinely use a bridge plate? Okay, okay, yeah. And I think it's a good thought because when the carpus is unstable, one of my indications to use a bridge plate is when the carpus is kind of dislocated with regard to the shaft. The problem with trying to just do a bridge plate in isolation for this is that you rarely get a good articular reduction. So using a bridge plate in isolation isn't going to reduce these, this lunate facet piece.
I guess you are maybe pointing that way too. You can put that lunate or volar fragment back where it's supposed to be, plus minus the styloid, plus bridging if needed to be. I think the decision is more so after you fix the volar and maybe radial styloid too at the same time, should you go dorsal or IF versus bridging plate? I think that's the question in this case, because it's 21, you want to make the, I mean, this is like a peel-on in a 21-year-old, right? The better the articular reduction you do, you know in the long term is going to be better. It's not like 70-year-old. In a 70-year-old, I think bridging probably would work fine, bridging only, but articular part, you got to, volar and dorsal piece, articular pieces, I think you got to put anatomically together if possible. Dorsal approach and fixation versus bridge plating, you guys tell me which one is better regarding the stiffness, range of motion, function.
Yeah, I mean, I don't think that I don't think I could reduce this piece dorsally with a bridge plate. I mean, I think I would be hard pressed to do that. I think you know the only way you can do it is open.
Yeah, so this is a high energy injury, multi-fragments, right? If you said sometimes when you reduce it, it actually looks pretty good in the splint, and you get CT scan and the articular surface looks acceptable. That's when I would probably consider bridge plating. But then this for me is not acceptable. It's still split in half, and the bridge plate won't do anything. It'll be basically like OIF, orthopedic internal fixation, right? And so when I first started doing fragment-specific fixation, I would think that's the only thing that could fix this. I think I could still try to potentially fix this with a single plate. I think I could. I've been using a lot of allograft, where I use the allograft to sort of build. I have some cases I'm going to show on Saturday, where you could actually see something like this and kind of build it up. It makes it pretty easy, actually, relatively easy, to build something like this into a construct where you could single plate. One useful information I could get from this CT scan is the size of the volar ulnar, so the lunate facet. If it's really small, and you're gonna, usually you try to build your distal radius from the volar ulnar corner. You have to have the best approach to get to it. How big? The best, there's two approaches that I know that are really, really good. The first one is the extended carpal tunnel approach. So you can go straight down to the lunate facet. The other one is the extended FCR approach, where you release the FCR all the way to the trapezial tubercle. And then you also release the radial column, and then you could retract the FCR all the way, like very ulnar, so you could go straight down on the lunate facet. A trans FCR might be a little bit difficult if you're doing fragment-specific fixation, because even like the jig has like a little handle, and the flexor tendons are in the way. So you can do it, but then I don't like to retract the median nerve that much. And so for me, this would be an extended carpal tunnel approach. The second reason why I would do an extended carpal tunnel approach is this is high energy. They're going to swell a lot. And if you do multiple incisions, by the time you're done, this will take me probably like fragment-specific fixation, like 3.5 hours. By the time you're done, they're really swollen. So I want to have a carpal tunnel release.
Okay. Anybody else want to do a different, like, what do you, so I think you really hit on a really important point, Nico, which is for me, the key to this is fixing the volar ulnar corner first and building the rest of the distal radius off of that. And whether you use an extended FCR or I just use a straight FCR approach or an extended carpal tunnel approach, it doesn't, whatever works for you to get down. Would you do it any differently? Anyone else? No?
volar and dorsal, which is rare. And I don't know if I've ever seen it, but typically I use an X-Fix, the mini X-Fix, as a femoral distractor for me. And I do the volar plate, and then I just make the little bit of an incision between the third and fourth. I can see right into the joint, so I can usually pin the articular surface from that dorsal piece. That dorsal piece is pretty big. Maybe I have to do more on that than I need to, but that's kind of what I was thinking.
I would also consider approaching this from dorsal first, just to sort of buttress not just that piece, but the entire corpus to realign it, and then that'll give me something to work off of. I think you can go volar too, as you guys were saying, but I think you could also consider starting dorsally and then working your way volarly, if you're going to go the fragment-specific route with multiple implants.
Kevin, in line what Dr. Dixon was mentioning, when you're doing this kind of impacted, shortened cases, do you use any traction during the case, like that finger trap?
That's a great question. I used to. So where I trained, we would always put people in traction, and they had an elaborate traction setup, and I carried that over for my first couple years in practice, and then I just stopped using it because I found that if I could. This one was done acutely, but there's a lot of different other ways to get length on distal radius fractures, and we've kind of worked around it, so I stopped using traction. So either I'll use a bridge plate as a distractor, kind of like the X-Fix concept, so sometimes I'll put a bridge plate on first, just to distract it out to length and then fix it, or there are other ways of kind of putting on a plate and using it as a clamp and you can get length distally using a clamp through the plate.
Yeah, I think we're kind of fortunate because we work in an academic center where we have like interns that could pull. So for me, if I'm going to fix this, if I go to the lunate facet, dorsally I'm going to do a capsulotomy, or if there's a rent, go through there just so I can look at the reduction. If you don't have someone to pull traction, when I was a resident, we used to put Kerlix in the fingers and 10 pounds off the table, and that'll give you traction, because I need to look into the joint. If I'm really going to go reconstruct this, and I want to get as perfect as a joint as possible, then I need to look in the joint.
Okay. So what we ended up doing was, Nico alluded to this, we use fragment-specific fixation. So the approach that we use is, I share Nico's view in that the volar ulnar corner is the most important part. So we went volar first. So I did an FCR approach. We reduced that volar ulnar corner, and that dorsal piece was still off. So we actually did a dorsal approach, reduced the dorsal piece, second with another fragment-specific plate. You could have used any dorsal plate. That is my one. This is the TriMed set. They do not have a good regular dorsal plate. I don't think you really needed to use fragment-specific for that piece. And I think the important thing with this is that for that style of radial styloid fracture, I think that I would have a hard time using a regular volar locking plate for this, not because of the size of the fragments, but because of the vertical nature of the radial styloid fracture. I have found that if you try to just put a volar plate on that this fragment here will just fall right off. And so if you don't buttress it with a radial column plate, you're going to lose that styloid piece. So that was our order of operations. So we actually did make a volar incision, just a straight FCR. I don't have problems getting over to the lunate facet with just a standard FCR approach. And then we did a dorsal approach to reduce the dorsal fragment here. And then when we found that the radial styloid was not caught by any of these, I actually I do a radial approach as well. So, a lot of people talk about using an extended FCR approach and getting to the radial column from the volar incision. I make a separate incision right over the first dorsal compartment and put a plate there. I have not had problems with skin breakdown or that skin bridge between the FCR incision and the radial incision. Okay. After all this is. You have 3 incisions on? Yes, 3 incisions. I know. Did you get them all closed? I got them all closed. And just like Nico said, this took about 3 hours, so about 2.5, 3 hours to do. And after all this was done, and we had let the tourniquet down, and we got all of our plates on, and I like where our column is and where everything looks, the DREJ is unstable. So I checked. That looks really good compared to what you started with. Yeah. So after this, so that's not, like my question for the rest of everyone is now you're 3 hours in, and you fix the distal radius, the radial side of the DRJ looks good. Nico, are you going to pin this, or what are you going to do? What would you do?
Yeah, so I'm going to talk about this, but then I would say if there's a big styloid piece, and one thing you look, I'll discuss this more on Saturday, but it's something called a coronal shift. Coronal shift, which is the distal radius is like radially shifted. If you're, for some reason, if your distal radius is the radial portion, if the distal radius portion is radially shifted, it's not, you don't actually go after the TFCC first, you actually have to fix the radius first. But your alignment looks really good there. So next would be, do you go after the TFCC? Do you open, do you pin? You could actually, I think you could actually pin it. You could actually just keep it in supination, or you could go make an incision and then go fix up TFCC.
When you say it was unstable, it was reduced but unstable.
Yeah, so it was reduced. I mean, it looks reduced here, but it was quite clearly unstable in all positions.
You just want to keep it reduced while it heals, so you can do it in cast, can't you?
Yeah. The problem with this patient, and we thought about doing this, the problem with this patient is that on the other side, he had a distal humerus that had already been fixed, that had an osteotomy as well. So he's already in a long arm splint on the other side. And so there's no way I was going to put him in 2 long arm splints. Yeah. So that's another consideration. We thought about just doing that.
One technical question, Kevin. Why this K-wires instead of screws from the radial column plate?
Yeah.
Or even from the other plates?
It's the design of the TriMed set, because the function of those K-wires, I found it's not really you're not reducing it through those K-wires. They're just keeping the plate from windshield wipering, from moving on the radius kind of from dorsal to volar. They're just holding it in place, because really what's happening is that the plate it's a buttress plate. So if you put it down, it's pushing the bone in. All that matters is what's keeping it in there are the screws proximally. So you just really need those K-wires to hold the position. I think the reason why there are K-wires is because this plate is meant to be placed right underneath the first dorsal compartment so that you don't get hardware irritation. So it's like those K-wires are flush, and I have yet to have to remove one of these plates because it's irritating the compartment.
I agree with the radial plate. That dorsal piece looked big enough that I thought I could catch it from a volar plate. And all I'm doing is open it between the 3rd and 4th just to make that articular surface. You didn't feel like screws from the front. You needed a plate on that back side, you thought?
Yeah, I mean, I think.
And why did you need that? Was it comminuted, or you wanted more of a buttress plate?
I think the initial injury, right? You are worried that this dorsal piece is going to escape. I think that's probably
My biggest concern is exactly what Uku's saying, is that the initial injury had the carpus going back dorsally, and I've had problems in the past. You can see it if we do the next case. We can talk about it. Where if you have a plate on the other side and you're not buttressing it, even if you have good fixation, the fracture will just fall off the dorsal side. So I'm pretty aggressive about doing this.
Was there comminution back there?
Yes, there was a lot of comminution back there. And, I was kind of, once I had done a volar plate, the fragment-specific volar plate, then you cannot catch the dorsal side with that. The tines are designed just to kind of catch that bone piece. You're not going to be able to get to the other side with that plate. All right. So because we already had a dorsal incision on this patient at 3 hours, we fixed the DRJ, the TFCC, with a suture anchor, a single suture anchor placed in the radius through the TFCC, and repaired it. So, and he was stable after that. So these are his X-rays now at 6 weeks. You can see our tiny little suture anchor over here. This is our repair. His DRJ has remained reduced. He actually had full pronation and supination at this point. So I just put him in. I didn't put him in supination. I just put him in a short arm splint and let him heal. And so he regained motion. I think the last time I saw him, he was having some problems with his elbow fixation, but he was regaining his flexion and extension. So I think I have one more slide on this patient. So he had full pronation and supination. When we saw him, his DRJ was stable, and he was working on getting his flexion and extension back, and that's to be expected. So for me with this case, you know, you have to be able to use fragment-specific fixation when it's called for. The bridge plate is not always the answer, even though it can be very helpful in comminuted and unstable fractures. And really, after all this work is done, you really have to stabilize the DREJ as well.
For this type of injuries, there's one paper I know from Harborview, Jerry Wong, that looked at outcomes on like 20 patients or so, like high energy distal radius fractures, and then so what you can tell the patient just from this small observational study is that they'll have about pretty much full 90 to 100% supination pronation, especially if you go after the DREJ, like make sure you reconstruct it volar and dorsal. In terms of flexion extension, it's about 70 degrees, and grip strength will be about 70% of normal.
Kevin, do you ever pin the DREJ? And if you do, what position do you pin them? Like what form? Station?
I have pinned them in the past, and I used to pin them in neutral. I have now since I prefer to just fix them with the suture anchor. And there's usually a reason. So the last one that I did, we had a patient that was another polytrauma, and I wanted him to be able to platform weight bear through his distal radius fracture. And so having, you know, K-wires sticking out on the ulnar side is not helpful. So a lot of times in polytrauma, I'd rather fix it and have it all closed rather than have wires sticking out for them to bear weight on.
Great, thank you. Scott?